Welcome to this webinar today being co-hosted by the Reproductive Health Supplies Coalition and the Population Council. This is Sophia Asan of the Reproductive Health Supplies Coalition, and we're so glad that you joined us today. Exploring the intersection of reproductive health and climate change is a key programmatic area within the Coalition's 3-year program of action. We're really keen to promote understanding of the challenges and realities that our members face, to identify means for adaptation, mitigation, and resilience, and to help bring forward and support collaborations across the spectrum. So please remain muted throughout this event unless you are speaking to everyone. We'd love for you to introduce yourselves if you'd like in the chat box by entering your name, your organization, and the country from where you're joining us. Also, feel free at any time to enter your questions or comments into the chat box. We welcome those, and while we have created guiding questions for our distinguished panel, we will fit in additional questions as much as possible as time permits. And it's my great pleasure to now introduce a colleague, Ricardo Regules, who is a geographer with a background in biology and a PhD in population studies. Ricardo has worked with the Population Council since 2019, and he's currently a consultant for the Population, Environmental Risks, and Climate Change Initiative, also known as PERCC. His work focuses on demographic and urbanization projections related to climate impacts. In Mexico, he has led research and programs advancing sexual and reproductive health and rights, particularly among adolescents and youth. Ricardo's recent studies also explore the links between climate and mental health among young people, as well as shifts in fertility preferences during crises. So with that, I'm very pleased to hand off to Ricardo.
Thank you, Safia, for the introduction. And thanks also to the Reproductive Health Supplies Coalition for co-hosting today's webinar. We are very happy to work together on this, which is part of the PERCC initiative at the Population Council. As Safia has said, PERCC stands for Population, Environmental Risk, and the Climate Crisis. And it is a council-wide effort that supports studies and research on how climate and environmental-related events shape health outcomes, drive migration patterns, and disproportionately impact the most vulnerable populations. Our goal as an organization is to close important gaps in knowledge, create useful tools and data, and support better climate policies at local, national, and global levels. PERCC also works with a climate justice lens, recognizing that the people most affected are often those who have contributed the least to the crisis. So, as part of PERCC, this webinar is the first in a series of sessions where we will share findings from community-led case studies supported by the Council. Each webinar will look at a different aspect of the link between climate and health, and we hope that together they will be a space for learning and exchange across countries and regions. Also, at the PERCC initiative, we believe that at the heart of climate justice are community-based organizations, as they live and work close to the people most affected, making sure that solutions reflect real experiences. Supporting these organizations is not only fair, but from our perspective, it is key to building responses that are relevant, effective, and hopefully lasting. It is also important to say that the case studies we are sharing today were designed and led by local groups, bringing forward perspectives that too often remain invisible in global conversations. Finally, we would also like to emphasize the central role of young people as participants in these research studies, since they are often among the most affected by climate shocks, facing disruptions in education, health, and especially access to SRH services. That is why it is so important to hear directly from their experiences, so their voices can hopefully help shape policies and programs that are more inclusive and sustainable for the future. So having said that, today's session will feature 3 case studies, 2 from Uganda and 1 from Malawi, focusing specifically on how climate shocks such as drought, heavy rain, and cyclones disrupt access to sexual and reproductive health services. These studies show the particular challenges that women and adolescents face, as well as the solutions led by communities. They also remind us why sexual and reproductive health must be part of climate adaptation and disaster planning, and hopefully they will give us practical lessons for building a stronger, climate resilient health systems across countries. So we are very pleased to have 3 colleagues with us who will share their work and experiences. Each presenter will have about 10 to 12 minutes. So to our presenters, keep that in mind. And after the 3 presentations, we will have about 15 minutes for a Q&A. So to the audience, please feel free to write your questions in the chat at any time, and we will cover as many as we can. So to begin, I would like to invite Brita Atusimire, Co-Executive Director for Programs at Agrovision She Farmers in Uganda, and the PI for the study on climate change, health, and SRHR among rural and peri-urban women and youth in Kamuli district. She's a social worker, passionate about the education and empowerment of young women and girls. Brita, the floor is yours.
Thank you, Ricardo. And thank you everyone for taking time to join our call today. Can you hear me well?
Yes.
Thank you. I will proceed. Once again, my name is Brita Atsimide. I am the principal investigator for this research and also the co-executive director for the Agrovision She Farmers. On behalf of my team today, allow me share about the findings and the voices of women and youth from the study and the research that we conducted. Our topic looks at intersecting reproductive health rights among rural and peri-urban youth and women in Kamuli district. Kamuli district is a rural district in Uganda in the eastern part of this country, and is just like any other rural district affected by issues of drought and low rainfalls and poverty, mainly among women and youth in general. Among the challenges, I'll go straight to the challenge before I share the challenges, I'll just give a brief background of how the research was conducted. We used a mixed methods of research where we looked at household surveys, we looked at focus group discussions. These were for women and youth. And in the youth group discussions, we divided the males and the females alone. We also focused on key informant interviews where we looked at health workers, we looked at community local leaders, as well as some important people that usually are of influence in the community. Why this audience? Because we are looking at sexual and reproductive health, and you and I both know that it mainly affects women as well as young people or youth. I will proceed. We are looking, so we gave a focus on how to show what climate shocks interfere or how they affect health, and we are looking at prolonged droughts and the shifting rainfall. This comes in to affect women, most especially because women in this district or in the rural Uganda are the ones that take place in farming. So they're involved in a lot of farming, and usually these droughts affect them. That means that if they are not farming, there's going to be hunger, there's going to be famine, and it later produces more challenges in the home. For example, partner intimate violence that comes as a result of no food and malnutrition among children. Daily life impacts, we also looked at crop failure. I'll speak about migration here. In this very community, among the women still, when there's no food, they do not have money, and usually when they are stuck, they look at options like, where can we find a better life? And then they decide to get out of the country to go find greener pastures. And mostly they go to the Arab Emirate countries, and we have all seen, if you've not seen, I'll just let you know that there's a lot of sex trafficking and abuse that's been involved of it in these countries, from the stories we see on the internet and from the news. And that means that women in this case get to become victims of such circumstance. On the vulnerability, the reliance on rain-fed farming, limited health access, and entrenched gender inequalities. So like we are saying that the intersecting of these challenges, if you are following well, you see that one challenge sort of gets into another and then brings out a challenge altogether. So for instance, if there is a problem of food scarcity, which we see here, it later leads to domestic violence. And in this case, maybe a woman may decide to say, let me run out of the country to find better. And then they so end up experiencing abuse. So it is intersecting one challenge, gets into the other, and then leads to the bigger circumstance. Next slide, please. Thank you. Then here we are looking at sexual reproductive health rights impacts. We are looking mostly at access to services, and we are saying here that this disrupted family planning access, the stockouts, the long distances that mothers had to walk to find medicine. And in the voices of the community, mothers say that even when they walked to these health centers, after taking the very long distances, they still were not able to find available contraceptives at the health centers. And that was very absurd. So they return home, and what happens is they later still keep getting pregnant even when they're not able to look after the children that they already have. And we also looked at stigma. This was affecting the youth, especially when they walk to health centers for medicine and they are shunned just for being young people who are actively engaging in sexual activities, which shouldn't be a case, because contraceptives should be given to anyone that needs them, especially when they are 18 years and above. Complications in childbirth due to weakened maternal health. The weakened maternal health is also linked to the undersourced health centers where there's not enough medication, where mothers also still have to move the long distances. They're not able to afford better health services, so they end up still stuck in this trend where children are sick and mothers cannot be able to access the right maternal support. Adolescent girls and women are mostly and severely impacted by this, definitely. Next slide, please. We looked at the broader health and the social outcomes. We looked at mental health struggles, anxiety, depression, and hopelessness. They still mostly affect women who get to shoulder the responsibility of being at home with their children, looking for food, and all that. So they still, imagine you are home, you have so many children, you don't have contraceptives, you do not have enough medical care, there is no food. It means by all means you are going to fall victim of mental health and depression. Rising maternal risks, these are a result of malnutrition. We're looking at, remember when I spoke about the rainfalls and the droughts are not being there? Yes, so this means there's not going to be enough food being produced because of the rainfalls not being there. And this affects children. One mother spoke to us and said, some days she has to boil just water and lie to the children that this is porridge for them to just drink the water and sleep. So imagine in such circumstances, children having water for dinner, they are not going to be able to have the nutrients that they need in order for them to grow well. So malnutrition is definitely going to be a high impact. Increased intimate partner violence due to food stress. I spoke about this already, and the disturbing migrations as a result of women looking for better work, leading to trafficking and abuse. And I spoke to this too already. Next slide, please. Community solutions and resilience. We looked at village health teams providing services to the women, but these also are very limited. But it would be a good thing that if we empowered village health teams to go ahead and spread the gospel of sexual and reproductive health rights to communities and to mothers. We looked at women's groups supporting each other with savings and small-scale livelihood projects that they do at a small scale, where they do farming. They also engage in small activities like making soap, and these are able to help making sanitary towels. These are able to help them get some small incomes that helps them to survive on their families. The youth clubs emerging as spaces for awareness through, and although they are also under-resourced. Yes, this mainly was to impact on the youth, where we looked at the youth being able to have circles where they can speak freely, speak about the challenges they are facing, and are supported throughout this form in order for them to be able to have information so they can control things like school dropouts, teenage pregnancies, among others. Next slide, please. Takeaways, we looked at integrating youth-friendly SRHR services with climate adaptation education, which we believe is very important, that as we speak about the gospel of climate change, we cannot leave out sexual and reproductive health rights because these two move hand in hand. We recommended that we need to integrate sexual reproductive health rights and gender equality in the climate preparedness and adaptation framework, so that these are not left out, so that when we are addressing one challenge of food scarcity, we are also looking at how we can support this mother to have the right number of children she can afford, and how she can also be empowered to make some money and earn a living, which will in the end control factors like domestic violence. Next slide, please. We are saying that climate change is not just an environmental, it's a health, the dignity, and the survival of all people. And we are calling out women and youth, and would like to appreciate the Population Council for the support for this research this far, and we continue to invite them to continue to partner with us and to support us on this journey. My time is used up. Thank you for listening to me, and over to you, Ricardo.
Thank you, Britta, for those important points. Now, from another district in Uganda, I'd like to introduce Ruth Kisusa from the Community Concerns Uganda Initiative. Ruth is a public health researcher with expertise in sexual and reproductive health and her current work looks at the intersection of climate change shocks and SRHR. Today, she'll share her study on how heavy rain affects access to SRHR services for adolescent girls and young women in Mayuge district. Ruth, over to you.
Thank you, Ricardo. And since you've read out my research case study topic, I'll just proceed to the next slide. Next slide, please. So our study was implemented in Mayuge district, and Mayuge district is found in eastern Uganda. But what is unique about it is that it's mainly surrounded by Lake Victoria to the south. And because of this, it has heavier rains than neighboring districts, which of course, these heavy rains have impacts on livelihoods, lead to death at times, as reported in various news reports in the past decade, but also has impacts on access to services. But for us, what was more concerning with this case study was the impacts of these heavy rains on access to SRHR services for adults and girls and young women in Mayuge district. Next slide, please. So why is our study important, and why is sustained access to SRH services important? So Mayuge district currently has the second highest prevalence of teenage pregnancies in Uganda, with an estimated 50% of girls expected to get pregnant before 18 years. And so ensuring that girls have access to SRH services throughout the year, irrespective of rains or not, will ensure a reduction in maternal death, but also will ensure that girls are kept in schools because they have access to family planning services. And ultimately, in the long term, it will ensure a reduction in household poverty in Mayuge district, which continues to struggle with poverty and is one of with highest poverty in the country. So in terms of our study objectives, we had 3 study objectives, but the 2 highlighted on this slide is what the presentation is going to focus on. And we used qualitative methods to answer these 2 objectives, with the first being to explore the effects of extreme rains on adults and girls and young women and its impact specifically to access of SRH services, but also to examine the recommended strategies to ensure sustainable systems for continued provision of SRH services for adults and girls and young women in Mayuge district. Next slide, please. So in terms of our methods, this was a mixed method study as well, and it was conducted in 4 remote island and shoreline communities in Mayuge, and we reviewed health records for the quantitative components, and we are currently analyzing this data, and we hope to link it to rainfall data to see if there are any variations in the number of girls accessing family planning services or antenatal or hospital delivery during periods with heavy rains and versus periods with dry seasons and periods with moderate rainfalls. In terms of the qualitative component, we had IDIs and focus group discussions with adults and girls and young women, specifically those aged 12 to 24 years, but we also had key informant interviews with healthcare workers. We spoke to the SRHR provider specifically and the youth focal persons across 6 facilities in these remote island and shoreline communities. And next slide, please. I'll present our preliminary findings from the qualitative component. And so in terms of understanding of SRH services, most of the adults and girls and young women we interviewed had good understanding of SRHR, and they mainly defined it with regards to the services provided, like family planning, antenatal care, hospital deliveries, etc. But when we asked the healthcare workers what services were available, they mentioned that most services, including antenatal, postnatal, hospital deliveries, and family planning were available, but noted that cervical cancer screening, comprehensive GBV management, and youth-friendly SRH services were largely missing at their facilities, particularly in island health centers. And then in terms of alternative providers, we noted that the participants said community outreaches were available, but some also still use traditional birth attendants, and most of them went to private clinics, especially when it was raining heavily. Next slide, please. So in terms of the general barriers to accessing SRH services, irrespective of whether it's raining or not, both healthcare workers and the girls noted that there is still a stigma for adolescent girls and young women. There are myths about family planning services, and some participants linked using family planning to having asthma. And then there is a strong reliance on traditional birth attendants because of less judgment from community members. But also in terms of health system bias, we noted greatly from the participants that there is lack of privacy and confidentiality at the facilities. There is stock out of SRH supplies, particularly in the island communities. There are limited staff. There is language barrier in the island communities because of seasonal migration from neighboring countries like Kenya. And then economic barriers, of course, what mainly came out was poverty and the lack of transportation costs to go to the distant health facilities. In terms of geographical barriers, of course, it was distance to facilities. Next slide, please. And then these findings were specifically to the extreme rainfalls. We asked girls girls and the healthcare workers what SRHR issues they noted increased during periods of heavy rains, and they said that there is an increase of unplanned pregnancies, and the young girls and women were quick to note that during periods of heavy rains, socioeconomic activities are disrupted, and as a result, you find that the girls and their male partners find themselves in the same environment, which leads to increase sexual activity and thus unplanned pregnancies. But also rains also disrupt access to family planning services, which also contributes to these unplanned pregnancies. And most healthcare workers noted an increase in unsafe abortions, gender-based violence, and STI diagnosis. And then the healthcare workers also mentioned that adolescent girls and young women with disabilities were disproportionately affected. And most times you find that sexual violence cases increase during periods of heavy rains. And then also the other impact of the extreme rainfalls was missed appointments, referrals during emergencies, especially in island communities became or was difficult, but also in the mainland communities because of the poor roads, the flooded roads, there was an increase in transportation costs. And then in terms at the facility level, the healthcare workers noted that there is overcrowding, there is poor sanitation, and then most staff, especially in the lower level facilities, the health center tools, do not come to the health centers when it rains heavily. And then we asked participants if they have noted any seasonal variations, or if they can mention the month where they experience heavy rains. And there were variations across respondents, with some saying it's April and May, while others said it's October and November, which is really telling of the fact that the climate change crisis is truly happening. And this is noted with the changing rainfall seasons. Next slide, please. And so this diagram here and the quote from one of our health youth focal person summarizes the interlinkages between the normal barriers that adolescent girls and young women face in accessing SRH services, but also the compounding effects that climate shocks and more specifically extreme rains have, and how they affect access to SRHR services. Yeah, thank you. Next slide, please. So in terms of coping mechanisms, the adolescent girls and young women mentioned that most times they wait for the rain to stop, but in the event that it's an emergency, like they have to go and deliver, and then they use motorcycles to go to the health facilities, even with the rain. And some of them say because of the increased transport costs, they have to borrow money and then work towards repayment. and then others say that they go to private clinics. In terms of the facility responses, healthcare workers say they involve the VHTs to scale access to family planning services when the rains are heavy, but also the healthcare workers noted that the community leaders played a key role in trying to find temporary solutions, like creating temporary shelters. In a facility called Bonda, they mobilized resources and built a temporary shelter, a tent, to ensure that there is enough space for girls accessing SRHR services. Next slide, please. So in terms of the policy and the gaps that we noted, at the moment, youth-friendly services policies exist in Uganda, but are very weakly implemented, mostly because of health system barriers, also like limited space at the health facilities, which limits privacy and confidentiality. Our referral systems are limited and not inclusive in island communities, with some healthcare workers say that they prioritized mothers who wanted to give birth over those girls and young women who had advanced STIs in the event that they had to refer, because of few boats and ambulances to take these girls to higher level facilities. And then we also noted, sadly, that while reviewing the SRH records, that there is a lot of missing data, especially PERCC post-abortion care services are not explicitly reported by healthcare workers for fear of incrimination, as noted in the quote from this nursing officer. And then there are missed opportunities to also address modern family planning side effects, which leads to discontinuation of family planning services and contributes to unplanned pregnancies as well as unsafe abortions. And then also it was quite saddening that NGO and partners are reluctant to support health facilities in island communities, mainly because they are difficult to access, despite in-charges from these facilities reaching out to these NGOs to help scale SRHR services. And then also, currently, there are no clear district or national guidelines in Uganda linking climate change and SRHR service continuity. Next slide, please. So in terms of recommendation, we recommend that there is need to strengthen stakeholder involvement from grassroots to the district level and to the national level, and really to ensure that everyone is involved, from the young girls to the VHTs, to the healthcare workers in providing services to adolescent girls and young women. And then there is also need for external NGO support, especially in island communities. There is need for more infrastructure, because these youth-friendly corners can only be created when there is more space at these facilities. And there is need to provide hard-to-reach allowances for island staff so that they can be encouraged to continue service provision. And there is need to train service providers on youth-friendly SRHR to reduce stigma for girls accessing SRH services. And also there is need to integrate digital health approaches like callback systems for adolescent girls and young women during emergencies, but also to ensure that these girls can use these systems to access these services even when they are not having an emergency. And also we recommend that there is need to explicitly include SRHR in Uganda's climate health national adaptation plan, because it's currently missing, and this will really foster or ensure that girls are provided with SRHR services in future climatic shocks. So in terms of acknowledgement, next slide, please. I would like to acknowledge the PERCC initiative for funding our study. I acknowledge my co-investigators, our research assistants, the district leadership, and the study participants. Thank you very much.
Thank you, Ruth, for that clear presentation. Now we move to Malawi, and I'd like to welcome Nisili Mushani from the Center for Education, Promotion, and Advancement of Rights of Adolescent Mothers. Nisili He's a social scientist and policy researcher with broad experience on climate resilience, gender equality, and SRHR, and she's currently completing her PhD in development studies. Today, she'll share her research, Surviving the Storm, which looks at how cyclones affect access to SRHR services in Malawi. Nisili, please go ahead.
Thank you, Dr. Ricardo. Good morning, good afternoon, good evening. It's a pleasure to be part of this seminar today, but also I'm honored to really share the experiences of the Lake Chura population, how they actually deal with cyclones when they happen, specifically related to access to SRHR. Next slide, please. So this study was carried out in Zomba, that's in the traditional authority Mwambo. This is Zomba district in Malawi, specifically the community surrounding Lake Chura, the Lake Chura basin. So we did the study in the 3 villages, Kachulu, Likapa, and Inchenga. We had, this was a qualitative study, and we had almost 96 participants across 6 different data collection methods. We had community members. These are the disaster survivors who made up of 65% of the participants. We had key informants, which are healthcare providers, traditional leaders, religious leaders, but also disaster management coordinators. The study participants in total, I've mentioned that there were 96, 58% were male, 42% were female, and then the ages, of course, ranged from 18 to 72. The methodologies that we used, we had focus group discussions, in-depth interviews, photo voice, community dialogues, but also key informant interviews. Moving on to the next slide. So the background to this, we noticed that Malawi have had issues when it comes to climate change. Most way past years, it used to be droughts, but now in the past kind of 8 years, we've noticed that there's been an increase in cyclone frequencies. For instance, we've had Cyclone Anna in 2022. There was Cyclone Freddy, which had a large impact on most of the communities in the southern region of Malawi. But also just basically from 2019 to 2024, the cyclones have been happening a lot. Now, with this repeated cyclones happening almost each and every year, there have been repeated destruction, especially when you look at communities in Zomba surrounding the Lake Chura. These are communities that actually grow, but also rely on production of rice. So these cyclones actually they sweep out all the rice crops, especially when it's during the harvest time, creating severe food insecurity. But also when it comes to infrastructure, roads become impassable, water systems are contaminated, and also houses are destroyed. Next slide. So what does this mean when it comes to the members in these communities? You know, these are remote locations, like I've said, and then they're dependent on climate-sensitive livelihoods. Most of them, they're either fishermen or they are farming households. Due to these rural areas, there's limited healthcare access, as usual. And then within these communities, when we're doing this study, we noticed that there's only one hospital which is serving multiple villages. This is the Likangala Hospital. But then apart from that, when you look at these communities, the already existing poverty amplifies these repeated climate shocks, the issues that households are actually having, but also at individual level, poverty levels keep on increasing year in, year out. Next. So what our study actually now find out is that the way the cyclones have been happening over the past years from 2019 to 2024, before I actually mention the actual impacts, I would want to mention that prior to our study, we had planned to look at the effect of one cyclone. That was Cyclone Freddy. But when we went to the district authorities actually highlighted to us that cyclones have been hitting Zomba district for a couple of years. It was not just Cyclone Freddy. So they actually asked that our study should actually look at the general impact cyclones now have on SRHR in Zomba, not just one cyclone, but for the cycle that happened 2019 to 2024. So from our studies, some of the issues that we actually find out, for instance, when it comes to SRHR impacts, let's look at maternal health, but also family planning. One thing that the members pointed out was the transportation barriers. You find that pregnant women resorted to giving birth at home or during evacuation, because now with the infrastructure which is down, they cannot actually cross to go and reach the health facilities, their nearest health facilities. Apart from that, there's a family planning disruption. So this now leads to services being commercialized. For instance, contraceptives were being sold despite these, they are supposed to be free. In Malawi, there's a policy where contraception is supposed to be provided to actually the population that are using it for free. But then once there's this disruption of services, you find that now other people would start selling the available contraception to the members of the communities. Apart from that, due now to roads being inaccessible, people cannot pass to actually reach the nearest health facility. It also increases the transportation cost. Just like one woman said, and I quote, "When the cyclone hit, I was pregnant. Then I struggled to reach the hospital because of severe flooding. But then likely some elderly women in the community helped us to give birth at home." And then another participant said that there are some home-based private clinics who are now resorted to selling the family planning services to them. So for a woman who is really, they know what they want, the number of children they want, but then in that instance, they say someone is using, of course, the short method contraception. If they really are in need, they wouldn't wait until the roads are passable to go get their choice of contraception. So in that case, people had to spend out of pocket money to actually get their contraception. Next slide. When it comes to gender-based violence escalation, participants mentioned that there was systematic exploitation, especially in the camps that people actually have to be taken to after their homes have been destroyed. This was due to food insecurity, which actually now led to coercive sexual relationships. But despite this increase in gender-based violence, we find that actually it was not just communities, but there was a campaign that actually started. This is what participants called the My Body is Not for Exchange with Flower campaign. One religious reader actually mentioned that people found a chance to sleep with the girls anyhow during the cyclone because the girls could not say no since they did not have food. So there was that thing of, okay, you sleep with me, then I give you food. The My Body is Not for Exchange with Flower campaign was actually started by the UN Women together with an organization called PERCC, which actually looks at the legal rights of young women and women in displaced places. Next slide. The health systems failures. So the study also tried to look at what happens when cyclones hit to the health system itself. So one of the things that actually the study found out was that when it comes to implementation, that's the MISP implementation gaps. Many healthcare providers had never heard of the MISP protocols. So the MISP protocol is where these are in a given district or in a given region, once there is the climate change disasters, this is supposed to be initiated to make sure that the population do not miss on the SRHR services that are there. So due to the cyclones, there was now delayed provision, of course, of services. Services arrived days or to weeks rather than hours after disasters. Apart from that, the study also found that there was a lot of youth exclusion, especially when it comes to adolescents. They were consistently overlooked despite them actually being a significant portion of the affected proportions in Zomba. Next slide. So despite all these challenges, we find that the communities actually, they had their own solutions, but also to make sure that communities are resilient. One thing that the study found out was the traditional knowledge systems. So despite the women being stuck and then they're pregnant, but then it's time to give birth, they actually resorted to using the traditional birth attendant networks. There was the usage of indigenous early warning systems. Instead of course, the road network is down, infrastructure is down, so communication is also cut. So as cyclones are coming, actually now communities resort to using drums to warn each other around the communities that cyclones are coming. But also apart from that, what we found very interesting was the flexible leadership that came out or that arises during cyclones. You see, as policies, when it comes to family planning, SRHR, I think countries, we've been moving so much to advocating for women to give birth at healthy facilities. But now when cyclones hit, actually like for Malawi, there is a penalty for a woman who gives birth at home. Now during cyclones, we found that traditional leaders temporarily suspended those penalties to allow women to give birth during these emergencies. And then apart from that, there's the local innovation and also manufacturing. Participants mentioned sanitary product production, where community members now were trained to make pads using different cloth pieces. But also alternative transportation, just to make sure that the health systems continue to provide the services. So we noted that boats, but also bicycles were used for patient evacuation, but also for medical supply transportation during the cyclones. And then the last one is looking at the community organizing against exploitation. Of course, I've mentioned the grassroots campaigns, the My Body is Not for Exchange with flower t-shirt initiatives, but also the UN Women and other organizations just going to talk to the survivors of cyclones, especially in the camps, but also in the communities, that whatever help that they're getting is not supposed to be exchanged with sex. It's supposed to be for free. But also apart from that, women formed discussion groups in the evacuation centers where they would get together to discuss issues, that the challenges that they're having, but also try to get one of them to talk to the leadership in the camps where they were actually being housed. Apart from that, there was also the awareness building, recognizing that adequate food provision could actually prevent sexual exploitation. This was something that came out again and again, whereby we noticed that when cyclones happen, of course, the first thing that responders would look at mostly is the housing, but also the food provision. And then, of course, these other for instance, SRHR comes maybe second or third in the planning, but also the implementation of the interventions. Next slide, please. So what are the takeaways, but also scalability potential from this study? One practical strategy that other communities might want to borrow, or participants actually mentioned, was pre-positioning SRH supplies with trained community health workers. Our study found out that the nearest UNFPA emergency supplies were in Blantyre City. This is another district which is 1 hour away from Zomba. So sometimes this would actually create delays during emergencies. The key recommendations for policymakers. From our findings, most of the frontline providers were not aware about the MISP and when it is supposed to be activated when cyclones hit. So probably what we need is to reduce the disconnect between district level policy knowledge, but also the community level implementation representatives. There's a need for healthcare workers, traditional leaders, but also community health workers to actually receive this regular MISP training, with accountability mechanisms and not just district officials. And then the third one is the integration priority. There's a need to include SRHR as priority services in all disaster response protocols. So rather than treating reproductive health as a secondary need, there's a need to actually integrate it in SRHR services into disaster response from day one, alongside food, shelter, but also security concerns. This requires dedicated budget lines, but also performance indicators for emergency SRHR programming. Next slide, please. So with this, the voices of the 96 participants from Lake Chula communities provide not only evidence for systematic failures, but also roadmaps for transformation. So as climate disasters increase in frequency, but also intensity, the patterns documented in this study will affect all the numbers that are there, the vulnerable populations keep on increasing. So there's a need to actually act now instead of waiting for the next storm. Next slide, please. And these are just I would like to acknowledge my team members for this study, Caroline Kandawire, Kate, Dr. Collins Mitambo, Mariana Jumbe, but also our research assistants from SEPRAM, the Zomba District Council, Zomba Health Office, but also especially the research committee from Zomba, the Malawi Police Services for providing us security, but also protection protocol during our research. Most importantly, the community members from Lake Chirwa Basin. Thank you.
Thank you, Nisili. And thanks to all three presenters for sharing their valuable work. We now open the floor to Q&A, which will be moderated by my colleague Deepshika Sharma, also from the PERCC initiative at the Council. Go ahead, Deepshika. Thank you. Hi, Deepshika, I can see you, but I don't know if you can hear us.
Yeah, I can now. I was sorry, Ricardo. I was unable to unmute it, but now it's fine. Thank you so much, Ricardo, and thank you so much to our presenters for the wonderful presentations and actually sharing the outcomes of the case studies. So we have a couple of questions, and I would like to start with one of the questions being asked by Aslam from Peace Foundation. It's for Britta, and it's trying to understand like how humanitarian organizations are playing their role providing assistance on post-miscarriage management, menstrual health, and family planning methods. Mostly they prefer shelter and food. And what he or she has referred to is that in Pakistan, they do not pay attention towards these methods and RH. So what role is basically humanitarian organization playing in providing post-miscarriage care? That's to Britta. Britta, over to you. I hope it's clear.
Thank you. Yeah, sure. Thank you. So what humanitarian organizations are doing is the few that are in support or provide these services like sexual reproductive health services are not many. They are few, and some of these cases, for example, like domestic violence are they are delicate cases, and some of these organizations do not want to take on the responsibility to follow up cases with police. So usually they'll just say that's tight, you can hand it over to the police. And we know that with police, it usually takes so long to get feedback. So I should say some are there, the humanitarian organizations are there, but the services they offer and what they support on is limited. That's what I can say. Thank you.
Thanks so much, Britta. And so another thing which also you can find in the chat is that they've mentioned about the case studies which they have been doing on the flooding situation. So you can definitely write to them. Another question or comment to Nisli is that the UN organization and other humanitarian organization, they do follow the protection, sexual exploitation and abuse, and so exchange floor for sexual purpose. So, basically, why not an organization complain and set accountable to the exploitator, or, what are the policies around it? And also mention that UMOCA is the best forum for such complaints. So any thoughts on that, Nisli?
Thank you for that comment. So in Malawi, yes, we have the UN Women, and I know we understand there are protocols that happen, but it is also something that we've noticed over time, especially in the camps. This exploitation happen most of the times. But during our research, but also discussions with the local leaders, they have committees that actually document these incidences, and then they try to escalate them to the higher level. Probably that's why even in these instances, there was this campaign that was started by the UN Women to say, my body is not for exchange with food, something like that. So I think it arises from these documented instances, but also trying to make sure that they don't happen or minimizing the instances happening. Thank you.
Thank you. Thank you so much. And couple of comments has already been mentioned in the chat. You can see that considering the paucity of the time as well. One which is very crucial is that the HNAP for Uganda, it does have SRHR, as we all know, and in the table 3 where actions are outlined, advocates have worked really hard. So that thank you so much for that comment. And that Uganda has developed an addendum to include MISP in the National Disaster Management and Response Plan. I think it is very, very useful. So we must look at it. And I think it's also an inspiration to the other neighboring countries and other similar kind of geographies facing the similar climate crisis. We can also have a look at one of the reports published by YLabs. I think it'll be good to have some inspiration from that. So I do have one question for Ruth. Is that your study focused on 4 remote shoreline and Iceland counties. They face very unique access challenges. So, what did mainly the adolescent girls and young women from these island communities tell you about their biggest barriers to getting the services related to SRHR, especially during the extreme rainfalls or the extreme events?
Thank you, Deepshika. So the biggest barrier was transportation, especially in island communities. Participants noted that when it rains heavily, the Lake Victoria waters become what they termed rough. And in most cases, most boats cannot pass through those waters to the facilities. And even the available boats to go to the facilities will charge highly to take you there. And this forces most adolescent girls and young women to either forfeit the services or to use nearby drug shops or traditional birth attendants if they want to go for delivery services. Thank you.
Thank you. Thank you so much, Ruth. We, considering the paucity of time today, we cannot go ahead with further questions or comments. However, you will get the details of the today's webinar. And thank you so much. Over to you, Ricardo.
Thank you, Deepshika. And I'd like to thank again all our presenters and everyone who joined us today. We'll make sure that all your comments reach the presenters. And just remember that this is just the first in our webinar series. The second one will take place in early October, and you'll be hearing from us soon with more details. Thank you, Britta, Ruth, and Isili, and thank you everyone for joining. Have a good day, good afternoon, or good evening, whatever you are. Thank you.